lip. And what we forget, in case we operate only the lip, these are the sort of results we get. Now the deformity is clearly visible on the nose. So good lip will not take care of this deformity, and that is what we are going to talk about today. So just for the residents in the audience, so it is primarily the orbicularis oris muscle attachment which is responsible for most of the deformities. So it is attached on the anterior nasal spine on the non-cleft side, foot plates or medial crura and anterior nasal septum. There is unopposed pull which will rotate the medial element anteriorly, and nasal septum and columella will deviate towards the non-cleft side. And on the opposite side, it is attached to the nostril sill and periosteum of the piriform aperture and alar base. So it will make the nostril horizontally oriented. And these are the classic deformities which all of us should know so that we can address them individually. Not need to go into the details. So another thing to note is the nasal deformity varies with the type of the lip deformity. In case there is minimal lip deformity, nose is more or less fine. As the deformity keeps on increasing, so does the nasal deformity. So the natural, now we have understood what the deformity is and how it happens. So natural corollary to this is how to operate it. But for quite some time, there was a lot of discussion about when to do it. Because when we were residents, it was taught that primary rhinoplasty will have adverse effect on the growth. We let the child be, and then we can operate when the skeletal maturity is there. So let's discuss whether it is really applicable or not. Just for the residents, primary rhinoplasty is when you do it at the time of the lip repair. Secondary is when you do after achieving the skeletal maturity, and intermediate is anything in between. So as far as the growth is concerned, this concern has largely been refuted through very long studies both in unilateral cleft lip or in bilateral lip, and 15 years, 30 years studies. It has been found that there is no adverse effect on the growth despite extensive surgical dissection, and there is a varying degree of persistent deformities but no growth adverse effect on the growth. So whether the operating earlier improves the nasal outcomes. So again, it has been proven through long studies. There is definite improvement in the primary rhinoplasty group, and more harm is done by failing to correct the nasal deformity. What happens is the alar cartilage is locked and tethered in the displaced scar, and as the tip grows with the growing age, we have deformities which are difficult, the correction is difficult to achieve. And earlier the concept was, all of us are bothered about our looks when we grow up, when we are adolescent. So doing a septoplasty or rhinoplasty at 16 years of age is fine. But it has been found that it has a negative body image develops by 5 years. And there is negative impact on school-age children as well as their families. And the greater the deformity, and female patients will have a higher poor quality of life. So early rhinoplasty improves quality of life. So primary rhinoplasty, there is no adverse effect on the growth. It will improve the outcome and it will benefit the emotional well-being of the child. So principle of performing primary rhinoplasty at the time of lip repair is now well established. So what can you do? As there is, we need tip support. We need to develop muscle and soft tissues across the sill. This very step will correct most of the deformity, and we also have to correct the webbed nasal error. So how can we do it? Either through Macombe's approach, in which we don't give any additional incision, or through Tajima incision, in which we have to give one incision, inverted U-shaped incision, and trim incision on the opposite side. And thereafter we can suture the lower lateral cartilages to upper lateral or the septum. So before starting our process around 2002 or 3, so we did a study which approach to follow. So we did around 15 cases each of closed approach without giving any extra incision, in which alar cartilage was dissected, freed and mobilized and suspended. And another 15 cases in which the marginal incision was given, alar cartilage was dissected under vision and sutured with non-absorbable suture to the opposite alar cartilage. So we compared columellar height ratio, columellar angle ratio, nasal sill width ratio and hood angle ratio. What we found was, irrespective of the procedure, absolute nasal symmetry was not achieved during primary repair. Columellar height ratio and columellar angle ratio remained the same in both the groups during 1 year follow-up, and nasal seal width ratio and hood angle ratio worsened with time. In effect, no difference between the two groups. So this is what we follow now. So we'll approach the ala from both medial and lateral side through the lip incisions. We'll dissect in between the plane between the dorsal skin and the lower lateral cartilage, both on both the sides. And we have also started repositioning the septum primarily. The septum is separated and repositioned in the midline. And after doing this, after completing the repair, the cleft side lower lateral cartilage is hitched to the upper lateral cartilage using suspension sutures, Newdorf sutures. We can also call these reverse Macomb sutures because the knot will remain inside. And we use PDS suture. So this is the nose looks like on the table. This is another case with lot of anterior displacement. This is another case. And we follow the same principles in bilateral cleft nasal deformity. We do closed dissection and suture suspension. And somehow these noses behave better than unilateral because the deformity is symmetrical. So, and the benefit is carried in most of the cases bilateral through the childhood. And there is no need of doing anything more. Just a word about nasoalveolar molding, because these days more and more people are talking about nasoalveolar molding. There is definite improvement in short term, that is what we found out, both in unilateral and bilateral clefts, but there is the issue of earlier relapse. So nasoalveolar molding has to be followed by primary rhinoplasty to give best results. It cannot obviate the need of doing a rhinoplasty. So let's talk a bit about intermediate rhinoplasty. So what we found in our cases was, even after doing the best of the cases, there was some relapse. So around 15 to 30 patients of the primary nose will require some correction before 5 years of age. And we went into the literature, there is no standardized approach for that. And residual deformities are highly variable. And also techniques also vary considerably. But one thing is for sure, most surgeons will do less than a full rhinoplasty in these cases. So what we do? We usually do a preschool rhinoplasty around 5 years of age. Here we'll reposition and reshape the lower lateral cartilage. The same thing which we did at the time of the primary surgery, we'll try to sort of repeat this procedure. And since the lip is already repaired, we'll usually give a Tajima incision and use interdermal sutures. And again, since now we have exposure to both upper lateral, lower lateral the septum, we'll do lower lateral cartilage resuspension and also add a alar cinch suture. So this is how it looks on the table, and the results are maintained even after 2 years. So again, this patient in which primary was done, deformity recurred, and this is at 5 years of age and this is at 9 years of age. And again, we have done, this is at 5 years of age before doing primary rhinoplasty, and then again the follow-up at 9 years of age. I think this child will be more confident while attending school than this child. And somehow I can see it in her eyes also. So there will still be cases in which you will end up doing secondary rhinoplasty. So we have to understand what exactly the deformity is. All of us are aware of tilted tripod theory, that there is no support here. So this will lead to collapsing of the tripod, and the septum will displace and the lower part will get dislodged. So we have to correct this and bring the tilted tripod to its normal position. So common problems are, there is no tip definition, and also there is no lower lateral cartilage support. And because of lack of persistent support, there is a web which is created here, and the lower lateral cartilage is quite down. So we have to use reverse Tajima incision, and we can do a concal overlay cartilage graft. We do interdermal suture and support the whole of this construct with a columellar stud graft. So in cleft nasal deformity, we have under projected nose, and ability to gain and maintain this projection is the key. So the columnar strap which we put, it reinforces the medial crural rack of the tripod, corrects the buccal, medial and intermediate crura, increases the projection and functions as a central scaffold with tip structures are unified. We published this in ISCLPC journal in 2019. These are few of the cases. These are few of the older cases in which no primary rhinoplasty was done. These are some of the recent cases. So cleft rhinoplasty, there is wide variations of techniques, but there are enough long-term outcome studies so that we can define what to do. So we have to go beyond personal convictions. We have to go beyond what was taught to us initially. We have to look at the scientific evidence and follow the best practices. So in summary, think of the lip and nose as a unit. Always do a primary rhinoplasty because it improves the early outcomes. And these improvements appear to last. They may not be complete, they may not last completely, but partly they last. And they do so without adversely affecting the growth. And if there is a need, we can do mid-foot course correction. It will not affect the nasal growth. Ultimate aim is potentially a better final outcome. Thank you.
Thank you, Dr. Atul. Any questions?
Thank you, Doctor. Very nice presentation. I have a question regarding the lower lateral cartilage dissection. Like in other papers we have been listening for the last few years, total dissection of the lower lateral cartilage and then repositioning in the new position. Do you have experience about that and comparing the results of McCombs or other subjects?
So McCombs without a complete dissection will not be that effective.
Right.
So we usually separate only from the skin part of it. We don't separate from the nasal mucosa because that cartilage is usually very thin, and in younger age group, less than 6 months of age, it is difficult to technically achieve that. So we'll just use the same incision, the cartilage, the lip incisions, and reach from the medial as well as the lateral aspect to completely dissect it from the skin.
So you keep the skin attached?
We keep the nasal mucosa attached, and then we do nude of sutures and try to hitch it, if possible, to the septum, and if not possible, at least to the upper lateral cartilage.
I feel still there is that tendency to tilt it down. If you just completely dissect it, put in the new position altogether, will it be more effective or?
Provided it is technically possible. So that will require a complete incision, external incision. That is what we don't want to give.
Thank you.
Any questions? Thank you, Dr. Atul.
Thank you.
Thanks for the nice.
Most of the things which I will be speaking on. Yeah, just to recap, we all know this, the unilateral cleft noses. Essentially, there is a malposition and hypoplasia of the lower lateral cartilage. The dome is flat, and then there is a pathological tethering of the accessory chain to the piriform aperture. So as we move towards the bilateral cases, the deformity it keeps on increasing and getting worse. With the addition of a shortened and absent columella, there is a laterally and posteriorly displaced alopecia. So once we are planning about managing such deformities in cleft patients, we need to ask ourselves 3 questions. First is type of primary cleft deformity, like Dr. Atul just referred to now, like have we done something to the nose at the time of primary repair? Primary nose correction was done or not? What was that severity of the nose, the lip, whether it was incomplete, complete, unilateral, bilateral? And what if subsequently something was done at the time of like intermediate rhinoplasty, preschool rhinoplasty? These are important because the noses which you get, they result from these 3 questions, the answer to these 3 questions. So if the answer to these 3 questions is yes, then what we get is a mild type of deformity. So mild is something where the low lateral cartilage, there is minor deformities of the shape and contour. There is minor deformity of the skin in the form of hooding, and the columella is more or less normal. So this is one of the examples. This is one girl which had a bilateral, she had a bilateral cleft. lip nose deformity. Something was done. Actually, we don't know the history, but after evaluating, something was definitely done at the time of primary surgery. But she still has some residual, look short. It's a relatively short nose. The ala retracted. The columella is more or less okay. So once planning on these cases, to start with, what we have to do is that we need a solid central pillar on which to raise the tip. For that, we can use columnar strut grafts. I prefer using a septal extension graft. Once with long spreaders which tend to lengthen the nose. Once that is done, we switch the medial crura to the septal extension grafts. Many times this does not suffice. You will still have over-rotated nose. In that cases, just putting in a shield graft, it tends to increase the projection and derotate the nose. Here I am using a shield graft. This was essentially to derotate the nose, because you can see the nose was rotated. It was overly rotated nose, probably because of, most of the times it is because of the scarring. So what I thought about the alar retraction, there are many ways to take care of that, but here I used the alar grafts. It will be shown in just a moment. So the tip is getting some shape. Now we put in this rim grafts. These rim grafts are two straight pieces of cartilage around 1 mm thickness and around 2 to 3 centimeter length, just ending short of the tip. What they do is that they provide structural support to the alar rims, and it helps in just getting the alar retracted rims down. This is the final picture, the shield graft, we get the dice cartilage with the DCF and a cap graft. So many things were done, but for the tip, what I mentioned was septal extension graft, shield graft, and the alar grafts. You can see there is some improvement in the retracted alar. Intraoperatively, you can just make out the tip is getting better, and the ala also pushed down now. So, as the question, again coming back to the three questions, if nothing was done at that time, usually what we get is moderate or severe deformity. Now, there not only there is a deformity of the lower lateral cartilage shape and contour, but also added to it is the there is the mal-oriented. There is a problem with the orientation of the lower lateral cartilages, and we get extra skin deformities, and we start getting this columnar deformities, columnar shortening. This is again a case, you can see amorphous tip, no definition, and there is some shortening of the columella. It is just like reconstructive surgery where we recreate the defect. Almost you cannot find any medial crura. So the plan here was, after doing the upper nose and the middle vault, the septoplasty has been done, reduction has been done. Now, this here, the upper lateral cartilage will be used as spreader flaps to close the roof, to close the middle vault, which has been done here. Once that is done, so we start the tip work. Again, a solid central support. I prefer septal extension graft. It helps me not only giving projection but also rotation. You can rotate the nose, derotate the nose, improve the columnar labial angle. So then you start using the lateral crust to form, which is called as a lateral crural steel, to make the medial crust. On one side, it has been done on the left side. And on the right side, this is how we cheat. We take the part of the lateral crust and we use that part to reconstruct the medial crust, medial crura. Many times what happens is that the length is not available. So we may have to put in lateral crural strut grafts, because it is not only aesthetics, it's function also. So in order to preserve the external valve, we need to have patent. In order to have a patent external valve, we need to have, here you can see a small little cruel stud grafts on the right side only. Following that, dome creations, dome equalization switches, which we call as the transdomal switches, to form that classical diamond. I am using 5040 PDS. You can use Vicryl also. No permanent switches. So with this structural graft, the tip is now in a much better position. The projection is good, the orientation, the rotation, everything is better as compared to the previous situation. Just before the closure, we just reassess and see. Usually in such cases, one important thing is just the supratip area. So we need to be careful there. We should not be thinning it too much, because then we can get some problems. This is the 6 weeks post-op. The 3/4 view, right and left, the lateral profile view, slightly better than what he was, and you can see the worm's eye view is also much better. The projection is good, the alar retraction is better, the dorsal is good. So coming to the severe deformities, absolutely no columella. Most of us find that, and this is one such classical case of this girl where you can find there is no columella. Other than the amorphous tip, nothing is visible of the tip. So coming to the intraoperative part, again starting with the same, the timelines are the same. You put in a septal extension graft. It helps in lengthening the nose as well as providing a solid foundation for increasing the projection. Then this is the base. This is the basal suture. This is the where the foot plates, middle foot plates, are brought back to the normal area where to the base of the septum. This is the most important suture, because from here we start building up the nose, the tip. From here from this point on, what we can do is that we can reassess and we can fix how much projection of the nose is required. The middle crura are being sutured with the septal extension graft. Now once we got that, we need some cartilage, to form the middle crust. That again we are getting from little cruel steel. But in this situation, once we have dissected the little crust, we are not left with anything. Just see this, the amount of residual little crust which is left after little cruel steel. Almost nothing is there. So we dissect the lateral crura, whatever is left, the lateral crust, whatever is left of it, from the skin as well as the mucosa. Most of the times what we see is that in such terrible cases, we don't find much cartilage left in the septum. So we have to go to the rib. This is the cephalic resection. We need to have almost around 4 to 6 mm of at least the lateral crura to maintain the patency of the external valve. So this is what you call as the tip creation, dome creation suture, or the transdermal suture, what we say. Now this is the projection, the amount of projection which we have got with this procedure. So here what I am doing is that I am creating this lateral crural stud grafts from rib grafts. They are 1 to 2 mm thick pieces of straight cartilage, very fine, around 2.5 to 4 centimeter in length. The broader part goes laterally and the tapered part goes towards the dome. So now this is the creation of the lateral crura with lateral crural stud grafts. With this lateral crural stud grafts, we can not only, we can bring the lateral crura down also and improve usually the malposition which is there, which we call as the cephalic malposition, which we usually see in such cleft patients. These crura can be put in three directions, either in the normal towards the medial canthal area, or depending upon how much alar retraction is there, we can get it to the base of the ala or midway in between them. We need to create pockets just in the lateral in alar bases, and then we put them in the pocket so that they stay there. These are the dome creations, these are the dome equalization switches, the transdermal switches. Finishing it with cap graft. And many a times in such patients we also require some thinning of the skin envelope. We need to be a little bit careful about it, because if we do it excessively, we just create more scar. So that causes, once it heals, it causes more retraction and more, over rotation of the nose. So this is the 3 months post-op picture. So to conclude, cleft noses, we get various types, various grades of deformities, and the options which we are is, for milder situations, we can take it with sutures. But with the worse, like the moderate and the severe deformities, we require structural modification in the form of septal extension grafts, lateral crural stud grafts, composite grafts. And by categorizing these cleft noses into various grades, it just helps us to makes easy for us to plan such cases. Thank you very much. Thank you, sir.
Definitely we have a lot of questions regarding that, but
thank you, sir.
Thank you. Thank you, Doctor.
Thanks a lot, all the chairpersons and the speakers. We break for high tea for 10 minutes. It's served outside this hall, just on the first floor. And we have to be back here in 10 minutes. We are already running 15-20 minutes late. So all the speakers and chairpersons to be here on time, so that we can start the next session. Thank you.
अभी आओगे ना? यही हो ना? बोल कर दो। अति अच्छी चीज है ना? मैं स्मार्ट नहीं ये नहीं इसकी बात ही नहीं हो रही है इससे फाइन एक वो अपना लगा चुका ना सामान सारा
Session 3 of 19th Annual Conference of Non-Zone Association of Plastic Surgeons. I would like to call Dr. Prashant Tyagi sir, Dr. Farooq Ahmed Bhatt sir for chairing this session.
Esteemed chairpersons, seniors and colleagues in the audience. My topic is a bit of a mouthful. The posterior belly of the omohyoid muscle is a marker for suprascapular ligament identification to aid in nerve transfers assigned to SSN by posterior approach for upper brachial plexus palsy. Though my topic is rather long, I hope to keep the presentation short. The dorsal approach to spinal accessory nerve to suprascapular nerve transfer is advised or preferred by some because of the extensive zone of scarring that may be present in the region of the neck. There can be a double injury to the suprascapular nerve, one in the neck and second in the suprascapular foot. The other could be that a nerve graft is required when it is done through the anterior approach. The dorsal approach brings the target muscle neuropatization more in proximity, in close proximity, and therefore would lead to earlier recovery. It also spares the upper trapezius muscle fibers. These are markings of for the incision. The suprascapular nerve is marked in standing position. The medial point of the upper border of the scapula and the acromion are marked, and a point roughly midway between these is where the suprascapular nerve is to be found. The spinal accessory is marked from the point in the midline and drawn up to the acromion. Point 30% from the midline gives the position of the spinal accessory nerve. The incision is typically planned between these 2 points. Now the suprascapular nerve in the dorsal approach will actually be found, it is actually found in the going beneath the suprascapular ligament or the superior transverse ligament of the scapula. This is mostly felt by tactile identification. Some papers have reported an ultrasonographic marking preoperatively also. The markings are as described by Colbert and Mackinnon. Now, there are numerous challenges to identification of the ligament, and that is where this paper will finally lead. One is the depth from skin. Now, the depth from skin would include skin, subcutaneous tissue, the trapezius muscle, and in heavy-built people, a good chunk of the suprascapular muscle. This depth may range to up to 6 centimeters, 8 centimeters. Second, the muscle overhang. One may incise and reflect the trapezius muscle, incise it at the spine of the scapula and reflect it. But the overhang of the supraspinatus muscle needs good retraction. The suprascapular artery and vein typically lie above the ligament, and the nerve actually lies beneath it as it enters through the posterior neck, and then it goes beyond it, and then it comes up towards the scapula, beneath the supraspinatus muscle. And so tackling vessels in that depth and small field is also a challenge. Next, ligament ossification is a possibility, and it has been described in anatomy papers. The fat and areolar tissue will be found in proximity to any neurovascular structures, and again, through that, through scooping out of that fat, the suprascapular nerve has to be dug out. Colbert and Mackinnon very nicely described it, and I'll just read out these words. The identification of the ligament and notch is very tactile. The ligament is felt on the upsweep of the scapula with the index finger, and the hollow of the foramen is felt below the ligament. Now, coming to what this paper is about, the omohyoid muscle. It originates actually from the medial aspect of the suprascapular notch. Sometimes, of course, like in anatomy and everything else, there are variations. Now, these variations could be either the belly attaching all over the ligament, or an absent inferior belly, or a double omohyoid inferior belly. These variations have been described up to 15 to 20%. No scapular attachment, and that too on the unilateral side, has been described through cadaver studies in about 3% of adult population. We did 3 cases and 4 cadaveric dissections, one side only, to actually delineate how identification of suprascapular ligament can be aided. And as you can see in all these pictures, I have labeled the last one just for, you can easily see the nerve and the small belly. Now the trapezius and suprascapular nerve, supraspinatus muscles will be from lateral to medial to lateral directions. They'll be rather, let me say, transversely placed, whereas the omohyoid muscle would actually be placed craniocaudally. And so that, if one reflects the trapezius and then retracts the supraspinatus, one can easily see the only muscle that you will see there, a thin omohyoid inferior belly. And that will actually lead you to the medial edge of the suprascapular ligament. And then you can put in a mixture forceps and open the ligament and then gently scoop out the nerve and move on. These are some pictures from the cases that we've done, marking. And then on the picture there's a video actually. Dr. Akhil Ramarti will be speaking in it.
This is the posterior approach for the transfer from spinal accessory nerve to suprascapular nerve. So this is a bit of a tricky dissection of suprascapular nerve because it is very deep. Usually we feel the upper border of the scapula and follow it till the notch. But during dissection we always find there is the omohyoid muscle, the posterior belly, going to attach just medial to where the suprascapular notch is. So while dissecting, we first go through the trapezius muscle, then the fascia of the trapezius muscle, then we come across this omohyoid muscle which is going from craniocaudal direction and attaching onto the upper border of scapula. So just by following this muscle, we have reached the transverse scapular ligament, which is very clearly visible. So rather than guesswork and calculatory method, we can very clearly see this muscle. And this is a very good marker for the knowledge.
That also was the concluding message from the presentation, that just not going by touch and feel, we can actually visualize, try to visualize the omohyoid muscle, which you will see as a thin vertical strand of muscle, and then that will lead you to everything else. Thank you.
Because we are short of time, so just one question, please. I think there are no questions, so thank you so much, Dr.
Thank you.
Now I invite Dr. Vikas Karkar to speak on the role of microsurgery.
As we all are plastic surgeons and everybody knows, it is a specialized surgical technique which is dealing with what we do under the magnification, like a microscope, and with precision instruments we deal with very small vessels and nerves. So the main purpose of microvascular surgery is to do reconstructive procedures that, like we do when there is tissue loss, as in oncological surgery, we reconstruct the tissue, we can do reimplants, and when there is any vascular injury or something, we prepare the vessels under magnification. So, what are the indications of microvascular surgery in head and neck reconstruction? So, to start, basic is oncological. After any cancer resection, we know there is a defect which has to be reconstructed to restore the normal aesthetic shape along with normal function and the appearance of the patient. Microvascular surgery also is helpful when there is a massive trauma and there is soft tissue or any bony loss. We can easily reconstruct with microvascular surgery. Some congenital malformations like craniofacial anomalies can be managed with microvascular surgery, and post-surgical defects can be managed with microvascular surgery, like in osteoradionecrosis and also infections sometimes, and the defects can be easily managed with microvascular surgery. So, coming to the types of flaps. Depending on the tissue which we are using, it can be a cutaneous flap, subcutaneous flap, muscle flap, osseous flap, or a composite flap, which consists of all like fibular osteocutaneous flap, which contains bone, muscle, and including skin. So, what is the most important thing when we are going to deal with microvascular surgery is anatomy. Unless we know the anatomy, we can't do the microvascular surgery, because you should know where your normal and what is the normal anatomy, so that you can easily dissect the structures, especially the vessels like external carotid artery branches, facial artery, internal jugular vein. These you have to be very clear, so that you can plan your flap accordingly. You should, once you know the anatomy, you can easily plan where you are going to do the anastomosis and how you can reorientate the tissue which you have harvested from a distant place. Like any other surgery, there are challenges and there is failure in all surgeries, but with advances in the surgical techniques, the normal flap failure rate now is less than 10%, and even in the good centers it is 3 to 5% only. Before doing the surgery, we should know all the risk factors, and we should have proper consent, and informed consent should be, especially if the patient is a smoker, diabetic, obese, or there is previous history of surgery or radiation, as the results can be affected by these conditions. The second most important thing is post-operative care. Even the best of the surgery, if we don't identify any complication in the early post-surgical period, then we may land into the failure. So, post-operative monitoring is as important as the surgical technique. So, what are the important things in post-op monitoring is flap monitoring, visual inspection. If there is any change, if you see that there is a pallor, that means there is arterial insufficiency. If there is decreased capillary fill, that also indicates. If the flap is swollen, sinuous, that means there is venous obstruction. These can be easily seen and we can rectify at the earliest. Training the nurses is more important, because they will be with the patient most of the times, and they can be the one who can identify early, and we can reduce our failure rates. By doing microvascular surgery, the benefits is we can give a better speech clarity by repairing the structures and restoring the normal anatomy. We can help, especially in cancer tongue, by doing proper microvascular reconstruction of the tongue. We can help in restoring the swallowing and the speech. We can give better aesthetics by addressing all the subunits of the face, and we can get overall better satisfaction of the patient if we do a proper surgery. What the newer innovations are, like robots have come, they can do more precise anastomosis, especially in the areas which are in deep or less accessible normally. Then biomaterials are there, like we can use couplers and all, which can help in better anastomosis and early reduce the operative time. Then there is stem cells, which can help in angiogenesis. So when we do microsurgery, we think that we have done great, but the patient may not adapt it, because initially the patient will struggle with what he have given him, because he won't imagine the, and initially we have to do proper counseling and we have to do proper psychotherapy of the patient so that he should adapt and have a better quality of life. Long term, we have to follow the patients to check for any recurrence and any, we should assess our results and check whether the satisfaction rate of the patient or is it is improving day by day. So coming to some cases, the cheek and buccal mucosa. This patient having carcinoma, left side buccal mucosa, which is involving the skin. So we done a composite inside. We done a composite resection and a free anterolateral thigh flap was done. This is intra. This is post-op. Another case, carcinoma right side buccal mucosa. This is also involving the skin, so we have done a composite resection. This was initially 1 month after surgery. Later, commission was reconstructed. Another patient, this is a post-op case of carcinoma right side buccal mucosa. The patient presented early and we had done only in buccal mucosa was reconstructed with radial artery fold. And this is very flap. Another patient, right side buccal mucosa. This is a flap which is after 2 years the patient can good mouth opening and well settled. Next is tongue. Normally they say tongue should not be reconstructed, most of the oncosurgeons, but whenever we remove the tongue, we are dealing with the speech, swallowing and all. And even if we remove more than 25%, it should be reconstructed. And once you reconstruct, then you can realize the shape of the tongue, the swallowing function, the speech, they improve a lot if we do proper reconstruction. Like this patient, left lateral carcinoma tongue, hemiglossectomy was done and reconstructed. And then Mother Nature, it converts, see, the stitches are still there, but it has started mucalizing. This patient with near total tongue reconstruction. After radiotherapy.
Itu adalah asyik
The patient voice is clear and another patient carcinoma done. Hemiglossectomy was done, and this is just 3 weeks after the surgery. Breathe back karo. अंदर करो. मुंह बंद कर. नाम बोलो. Okay. तुम्हें बता दीजिए. Very good. So, see, when you reconstruct, then only you realize 25% of the tongue reconstructed, 50%, now 75%, and total tongue. This is after 2 years. There is a hair here that only says that this is not a normal tongue, otherwise it is not utilized properly. This patient with carcinoma soft palate, which was reconstructed and well settled. Then mandible. Why the mandible should be reconstructed in all the cases? The first patient is a case of failed mandibular flap. You can see it. And second is where bony reconstruction not done. And you can see a similar case when we have done a mandible reconstruction. This also required both bone, skin and all ossification, nice mouth opening and better quality of smooth. Some cases of mandible reconstruction. This patient with large mandibular tumor with fibula reconstruction. Left side hemimandible reconstruction. Left side hemimandible reconstruction. Segmental mandibular reconstruction. Pre-op and post-op with implants, and after complete dental rehabilitation done by our dental team. Left hemimandibular reconstruction. Near total reconstruction. Another near total reconstruction. This patient came after 3 years, and this is 3D of the patient. Same patient. Dr. Pooja is our ENT surgeon, trained in oncology. इलाज करो ऐसे का इलाज 2-4 साल में तो ऊपर में डिक्लाइन होगा स्टार्ट कर ठीक है लगभग 3 साल हो गए था नोट ठीक हो ठीक है तो ठीक है ठीक है इस तरह ऑपरेशन का था ऐसे ये अपना पूरा तुम्हारा करते से करी दर्शकों की तो तक मुंह खोल के कर हां याद आ जाता है बिल्कुल सही है बोल चाल शब्द बैठता है तो ऊपर देखो ठीक है तो लेसी हड्डी के तो लेसी जुगाड़े भी हड्डी लेसी जुगाड़े बात नाच तो देखो कोई चैलेंज प्रॉब्लम तो नहीं कर रहा कोई नहीं सर जब डॉक्टर को बढ़िया सुनाई नहीं दिया बहुत ਹੁਣ ਤੁਸੀਂ ਕਾਹਦੇ ਲਈ ਆਏ ਹੋ ਨਹੀਂ ਤੁਸੀਂ ਹੋਈ ਤਾਂ ਤੁਹਾਨੂੰ ਚੈੱਕ ਕਰਾਉਣ ਵਾਸਤੇ ਆਏ ਹੁੰਦਾ ਵਾਸਤੇ ਡਾਕਟਰ ਵਾਸਤੇ ਵੀ ਹੋ ਸਕਦੀ so take home microvascular surgery is now an indispensable part of any onco surgery of head and neck, and with proper anatomy and proper surgery and post-op care we can do good job and give a better quality of life. What is important after cancer is not only the years we had, but the quality of years we had that are more important. So, thank you.
Any questions? If there are no questions, I'll ask one question, Dr. Vikas. Very nice presentation, but I have a query regarding a defect in the tongue with 25%. On the one hand, you have a patient who has a cancer in the tongue with plus minus need for post-operative therapy or chemotherapy, with a simple closure. On the other hand, you have a patient who is being operated for a long time, extended operating time with a flap, which may or may not fail. If it fails, it will be a disaster. Your take on that?
Sir, if we think, definitely the time will increase. We add a microvessel surgery, at least we'll be adding 2-3 hours more. But if you have two teams, one team we can cut down the time. But the quality of speech, you see, once we remove the tissue is already less. And giving a post-op radiotherapy, it will gradually contract more. So
my question is regarding a simple closure of a tongue defect of 25%.
Sir, 25% we can do, see, but definitely after post-op scarring and all, we can give a better quality if we do a reconstruction.
Dr. Vikas. For the next talk presentation, I invite Dr. Karnal. He will be speaking on.
So, good morning everyone. I'll be talking on the digital implantation in pediatric stage 2. So, what is implantation? It is a reattachment of completely updated body part by re-establishing arterial inflow and venous outflow. And it offers a result that is superior to any other type of reconstruction or the best available processes. And it cannot be considered successful until the function is restored. So, the important thing is you have to take the history when the patient came, when, where and how it has happened. And also to take a note about any pre-existing illness, which is more relevant for the adult patients. So when the patient comes, we have to examine and rule out any other associated injuries and examine the amputated part, get an X-ray and done all the routine investigations. So then we have to make a decision whether we have to go for the reimplantation or not. And depends upon the patient's factors and injury factors, which include age, which is normal because we can reimplant in any age group. And injury factors include the type of injury, duration of ischemia, and the level of amputation. So the type of injury includes this can be amputation is a gluteal amputation or crush amputation or avulsion injuries. So the duration of ischemia, when it is warm ischemia, it can be up to 6 to 8 hours, and cold ischemia can be up to 16 hours. So the various classification system for fingertip amputations are there, like the my classification from in zone 1, there is from tip to the nail base of the nail, and in zone 2 from base nail to the DIP. Other includes like alien classification. So on the basis of flexor tendon also we can classify like level amputation zone 1 and zone 2. So what are the indications? So the absolute indication is the thumb implant, and there is a multiple digit implant or any amputation in the thumb or in the child. And the relative indications include a single finger and ring avulsion injuries. So the contraindications, it is when it is associated with life-threatening injuries and any comorbidities is present. Some relative contraindications include the zone 2 single finger or severely crushed or mangled part, any avulsion injuries which have a ribbon sign, or multiple level injuries. So the counseling of the parents is very important. We have to guide about the success rate of reimplantation, the cost involved, the complications, the period of hospitalization, rehabilitation, and the functional recovery. And very important is the written and the video consent, which will be taken in our institute. So the surgical techniques include two-team approach, one for the bench and the for stump dissection. Then the part has to be kept cold until the circulation is re-established, and either in the general anesthesia or the brachial plexus block we can do it. So the sequence of surgery include the dissection of the amputated part, then bone shortening and osteosynthesis, followed by extensor and flexor tendon repair, then arterial repair, vein repair, nerve repair, and the skin cover. So this is a photograph showing the dissection of the part and the tagging of the structures. So in digits 5 mm to 1 cm bone shortening can be done. And for osteosynthesis we generally use longitudinal K-wires, but cross K-wires and intraosseous wiring and screws and plates can also be used. So standard technique for the flexor tendon repair using modified Kessler techniques and running sutures for the extensor tendon are used. So the arterial repair when it's done, the point should be there should be no tension and there should be normal intima to intima contact. We should not hesitate to use the vein graft. An attempt should be made to use repair both the digital arteries. So the spurt test is very important. There should be a positive spurt prior to the anastomosis. But if it is negative, then we should consider that there should be further injury and we have to do the proximal dissection or resection of the intima. We should ideally warm the operating room and the patient and hydrate the patient. And also we can use application of piperacin and xylocaine. Then try to elevate the blood pressure and check for also metabolic acidosis. Sometimes we have to wait for 10-15 minutes to get a positive spurt test. So in the venous repair, we have to try to repair 2 veins for each artery. And preliminary arterial repair facilitates the venous repair. And we need at least 4 mm dorsal skin to get the venous repair. For in the zone, the my zone 1, volar veins are to be repaired. But sometimes it is not possible. Then the alternative, especially for the distal implants, are EV fistulas. Either you can use leeches or chemicals leaching. Or sometimes maybe remove the nail and scrape the nail bed and apply heparin. So the nerve repair is very important. So ultimately use of the implanted finger is on its sensibility. So it has to be repaired. So I'll be talking digital implantation 3 types, thumb implantation, single finger and multiple fingers. So thumb is responsible for over 40% of the hand, function of the hand. So the dictum is whenever it is possible we should implant the thumb. So I'll be showing few cases. This is a case of 16-year-old Toka injury or thumb amputation at IP joint level. So we had done reimplantation and arthrodesis was done with K-wire fixation. The patient had a good outcomes. Another case of 4-year-old child with Toka injury. It was just distal to the MP joint. This vein graft was used for the repair and was harvested from the volar aspect of the wrist. This is the final result of the patient. Another case of 4-year-old sharp injury. Again, we have to do the arthrodesis of the IP joint. And this is the X-ray of showing of the patient. And patient is able to do his routine activities. So another case of 11-year-old child with total amputation of distal to the IP joint, and the implantation was successful. And almost near bone short length was achieved. So the functional outcomes depends upon the level of injury. Best outcomes are for the distal to the IP joint. The more the proximal the injury, there is progressive loss of function. And poor functions, point is that if it is the implant is successful but the function is poor, still we have a stable post for opposition and grasp. So coming for the finger amputations, the amputation distal to the insertion of FDS is a favorable level. Zone 2 level amputations generally have a poor functional outcomes. And reimplantation distal to the DIP level is very demanding but gives an excellent results. So this is a case of ring fingertip amputation, a 16-year-old male. Then we have done a vein graft and volar veins were repaired. So this is the final outcomes. Another case of zone 2 injuries of 11-year-old child. In the Toka, there was a Toka injury and the reimplantation was done. It was successful and patient is able to write properly. Another case of 6-year-old patient, the Toka injury amputation at the middle of the proximal phalanx, and reimplantation was done. And patient is able to do his routine activities. This is a case of 6-year-old Toka injury and amputation at the DIP joint. Though the reimplantation was successful, but this was not the ideal case. There was slight deviation, maybe which can be corrected at a later stage. So the functional outcomes, again, the good functional outcome is present in the zone 1 injuries and poor outcomes in the zone 2, but very poor outcomes if there is crush or avulsion injuries. So coming on the multiple digit reimplantation, the techniques described is either you go for digit by digit approach or by structure approach. So the advantage of structure by structure approach is it reduces the operating time and also may improve the survival rate, and there is less chance of complication rate. But various comparative studies have shown that there is the similar survival rate, but the time duration taken for structure by structure is less. In our institute, generally follow structure by structure approach. So given the preferences we follow, thumb has the priority, followed by the middle and the index finger. So this is a few cases. This is a case of multiple finger reimplantation. It was a rope avulsion injuries. In this we had done reimplantation, but only middle and the ring finger survived. Another case of the thumb and the index finger, the amputation was done, reimplantation was done, and it was successful. In this case, there was multiple finger amputations, but only index fingers were reimplantable. So this is an interesting case. There was a amputation of index and middle finger, a 5-year-old child, Toka injury, but there was no suitable vein could be found. So in this, we had done chemical leaching, and post-operative we would try to salvage the fingers, and it was having the patient in good success outcomes. So sometimes there is a chances then where there's thumb and other fingers are involved, and thumb is non-implantable. A similar case in this, the thumb was non-reimplantable. So we had reimplanted index finger over the thumb, that is heterotropic reimplantation. So post-operative consideration is that proper dressing should be given with the requisite sprintage, and elevation is a must. We follow protocol of giving heparin infusion at 10 to 20 units per kg per hour for 3 to 5 days. And hydration has to be maintained. Regular monitoring is very important. And the patient is generally discharged on 6th day on antiplatelets. And we initiate the physiotherapy at 3 to 4 weeks. So 90% of reimplanted patients had a good range of motions, and 2-point discrimination also very comparable. And survival rate when done meticulously is good, around 82%. So the important lessons we learned that adequate bone shortening is a must, and we should have a low threshold for using the vein graft. High-end operating microscope should be available, and good instruments should be there. Use of volar veins and AV fistulas, and chemical leaching in the selective cases can be used. And the warm environment is a very must for this reimplantations. So to conclude, multiple digit reimplantation should always be attempted, and structure approach is better than digit by digit approach. And in case of selection, thumb and middle finger takes the priority, and it's a rewarding procedure with a favorable outcomes.
Thank you, Dr. Choudhury. Any questions?
How are you doing the chemical leaching?
So in this, we make a nick over the tip. We use a 11 number blade, make a nick over the fingertip. Then we inject around 500 units of heparin. Then make a wet saline gauze and soak with heparin and put it. And we generally ask the nursing supervisor, nursing staff to wipe it out. It should not, clot should not be formed. So this is how we try to do. And on a daily basis, we inject the heparin. So in 5 to 6 days, we have noticed that sometimes, but very important is this works only in the distal implant, maybe in the zone 1. If we are doing in the zone 2, it has no role.
For how many days you continue this chemical leaching? Because in few cases we used, but it requires at least 10 to 14 days to continuously do the chemical leaching, and sometimes it requires a blood transfusion, especially in children.
What we have realized that 5 to 7 days, after 7 days, there is establishing the venous outflow, sometimes of the healing of the skin that has approximately some outflows has established. So generally we follow the 7 days, but in that, if it has not worked, then it will not going to work.
Thank you. Any other questions? No more questions. Thank you, Doctor.
Thank you.
Now I invite Dr. Akhil Garg to give his talk on replantation strategies in upper limb.